Good morning to all of our live attendees today. We are thrilled you're here to engage in this exciting webinar.
I just want to empower us all to really believe that we have the collective power to shape this change. And then finally, just empowering us to really just value that our leadership is extremely valuable in this work. So as we move through this presentation today, I really want you and us to consider, as we learn about the public mental health care system, how do you and how do we collectively want to shape it from this point on? So a little bit about me. What gets me really excited is understanding kind of complex systems and how we can collaborate with partners and each other to make these systems better. I have been in this mental health policy world for about 5 years, so I still consider myself an early career professional. I studied public health and am just amazed at how much every day there is to learn. Even putting together this presentation, I learned so much about the mental health care system in California. I am queer. I'm cisgender. I identify as a woman of color, biracial, bilingual. I speak Japanese. I'm able-bodied, and I have educational and class privilege. And I choose to name these aspects of my identity because, again, I really am a believer that we all bring our intersectional identities to the work that we do every day, and that this informs the perspective and ideas and that we bring to our work. And I really value everybody kind of bringing their identities and perspectives to the work, especially in community-based mental health. And then finally, just wanted to name that I have lived experience as a family member of individuals who have struggled with serious mental illness at various points in their lives and have personally felt the intergenerational impacts of some of those illnesses. And something I think that is really important for us in this work is to bring and honor our lived experience, and that makes the work so much richer and better. In terms of my work, I am the Senior Manager of Integrated Health and Community Relations at Alameda Health Consortium and Community Health Center Network. So as Tiffany mentioned in my intro, I support the integrated behavioral health programs at our consortium's 8-member federally qualified health centers through partnership, policy, and program development. I really see my role as building relationships and partnerships with individuals, organizations, and other allies that believe in increasing the capacity and resources for community-based mental health and substance use services. And I'm always looking to connect with people in that space and would love to connect with any of you who are watching who share the same goals and values. So I mentioned Alameda Health Consortium. We're the regional association of 8 FQHCs in East Bay, California. Some of our member health centers are noted here on this slide. And in 2023, collectively, our 8 health centers have over 134 sites, including 20 mobile sites, like mobile vans. And we serve 290,000 patients, and that was about 1.4 million visits in 2023. A little bit about our history. You'll take it from my presentation that I really value history in terms of understanding how things work. Alameda Health Consortium was founded in the 1970s in the onset of the community health center movement. So we were really founded as an advocacy organization to support our health centers collectively at the local, state, and federal level, advocate for the expansion of community-based healthcare at our member health centers. And then Community Health Center Network, which is, we call them kind of sister organizations, was founded later in 1996 as a nonprofit Medi-Cal Managed Services organization and independent practice association, providing business and administrative support for community mental health centers. So later in my presentation, I'm going to be talking about Medi-Cal Managed Care. And so Community Health Center Network is really operating in that world of managed care as kind of the insurance arm. And then lastly, about our network, in 2023, our health center served over 65,000 patients for mental health and held over 140,000 behavioral health related visits. So that's in person and virtual. So just to go over a little bit today's flow, first I will cover some key terms and definitions. Then I'll talk about how FQHCs fit into California's public behavioral health care system. Then I'll do an overview of Medi-Cal Managed Care and federally qualified health centers. I'll talk about the values and challenges of integrated behavioral health models within FQHCs, and then the role of policy and advocacy when it comes to increasing access to behavioral health services at FQHCs. So we've got a lot to cover, and we'll take it from here. So some key terms. First, I want to cover behavioral health. I know this might be preaching to the choir, but just to make sure we're all on the same page. So when I say behavioral health, this is an umbrella term that encompasses mental health and substance use disorder. And then Medi-Cal. So Medi-Cal is California's Medicaid healthcare program. The program pays for a variety of medical service for children and adults with limited income and resources. And I would add medical and behavioral health services. And Medi-Cal is supported by federal and state taxes. So Medi-Cal is actually the largest Medicaid program in the United States, and it insures more than 1/3 of California's 39 million residents. And there's kind of two broad categories in terms of Medi-Cal. There's fee-for-service Medi-Cal and Medi-Cal Managed Care. And fee-for-service is also known as regular Medi-Cal. It's a type of Medi-Cal where the state pays doctors, care providers, and other providers directly for every service. So it's fee-for-service. Whereas Medi-Cal Managed Care is a type of Medi-Cal coverage where patients enroll in a health plan called a managed care plan that is contracted with a network of providers, pharmacies, and other doctors. So really we're seeing, it was really in the 1970s that California was the first state to enter into these risk contracts with managed care plans to serve Medicaid beneficiaries. And rather than pay for services on a fee-for-service basis, like to the left, there's really a movement. There's been a movement since then towards Medi-Cal Managed Care. And today, over 90% of Medi-Cal beneficiaries are enrolled in managed care in California, including many individuals with complex health, social, and behavioral needs. And really, Medi-Cal policy changes over the last decade have greatly expanded Medi-Cal Managed Care Plans' role in mental health service administration and addressing other social drivers of health. So what are federally qualified health centers? I've been throwing this term around a lot already. So Federally qualified health centers, also known as FQHCs, are community health centers that deliver comprehensive and culturally competent primary and preventative care services to California's medically underserved populations without regard to a patient's ability to pay for care. FQHCs are public or tax-exempt entities that must meet certain federal requirements to receive grant funding under Section 330 of the Public Health Services Act through HRSA, which is the Health Resources Services Administration, which is a federal agency. And in 2023, FQHCs in California served 5.4 million patients, 2 in 11 children, 93 of patients who are at or below 200% of the poverty line, 4.9 million uninsured Medi-Cal and Medicare patients, 349,000 patients experiencing homelessness, and provided over 2 million mental health visits, both in person and telehealth. So this gives you a sense of the breadth of the FQHC delivery system across, which includes both medical and behavioral services. I'm seeing some things come through the chat. And yeah, thank you, for engaging. I see Celine saying, in my experience with Medi-Cal, a lot of providers dislike fee-for-service due to low reimbursement rates. Yep, thanks for adding that, Celine. Great. Please keep comments and reflections coming in the chat. So just going over back to our flow, I'm going to talk next about how FQHCs fit into California's public behavioral health care system. So how I'm going to do this is we're going to study FQHCs and behavioral health in a few different contexts. So starting really big picture and then kind of zooming in. So we'll start with California's public behavioral health system. We'll talk about how FQHCs fit into the world of Medi-Cal Managed Care. And then we'll finally zoom in to the FQHC level and talk about a mode of care called integrated behavioral health. So I mentioned I love history, so bear with me here. I really do think that to understand how things work today, especially big systems, it's really important to understand kind of the trajectory and history of how things came to be. So, and just to name, between each of these milestones I've pulled out, there's so many more milestones that are so important that are not part of this presentation. So just to name that, I really tried to pull out some of the financial moments, not financial, foundational moments that shaped the system we have today in the context of FQs, managed care, and the behavioral health delivery system broadly. So even before FQHCs came into the picture, California's mental health system was centered around institutions, asylums, and mental hospitals. So California had close to 37,000 patients hospitalized in 14 mental hospitals in the 1950s. And these institutions had a lot of problems. They were expensive and susceptible to underfunding. There were huge racial and ethnic disparities in terms of who was served or not served by these facilities. They were overcrowded and under-resourced, and folks were really isolated from employment and social support. And controlling behavior was often the goal when these treatment facilities, not therapy, rehabilitation, or recovery. And then in 1957, the Short-Doyle Act, which was a California state policy, provided state matching funding for cities and counties that established and provided community-based mental health services. So this was really kind of the beginnings of what we know today as the specialty mental health system, which I'm going to talk about more in my presentation. In 1963, the Community Mental Health Act, which is federal, was signed by John F. Kennedy, provided support at the federal level for the development of community-based mental health care and treatment services. So we're already seeing here a pattern of, even before FQHCs or community health centers kind of came into the picture, there was real braiding of state and federal policy that played a huge role in determining the system of care that we had. Some more milestones. So in 1965, Medicare and Medicaid were created as amendments to the Social Security Act. That's at the federal level. And then in 1965 is when the first federally funded community health centers were launched in the US as part of a small demonstration program of President Johnson's Office of Economic Opportunity. So this was really when we started to see the birth of the community health movement, and harkening back to when I said that's when Alameda Health Consortium was formed, was to support these community health centers at that time. In 1966, California established Medi-Cal specialty mental health services formally. And then in the 70s is when California really started to pioneer managed care within its Medi-Cal program. And just to note here that even though it took a while, like many decades, for FQHCs to become, to integrate like mental and behavioral health services formally within their programs. And now I'm going to move into the next section a little bit of an overview of Medi-Cal Managed Care and how that fits into federally qualified health centers. So 2014 was kind of a key pivotal year when it came to behavioral health care deliveries at FQHCs, because California added outpatient mental health services to the Medi-Cal Managed Care program to comply with the Affordable Care Act. So this was really huge because it opened the door to the expansion of preventative behavioral health services provided through FQHCs and Medi-Cal Managed Care, building off of the specialty system that had been growing earlier. So this really represented an extension of the continuum of public mental health services here in California. So just to review some takeaways, the Affordable Care Act really greatly improved access to preventative behavioral health programs managed by managed care plans within FQHCs. And together, the specialty mental health and non-specialty mental health system are often described as our bifurcated mental health delivery system in California, which I'll talk more about in a second. I just want to pull up the chat to see if folks are commenting. Yeah. Okay. And keep going. So I just mentioned something, the term bifurcation. So this, over time, we've developed, just again to repeat, the specialty and non-specialty system. So the county behavioral health departments include managed mental health plans, which make up the specialty mental health system. And then on the right, our local managed care plans are responsible for the delivery of non-specialty mental health. So responsibility for delivering California's Medi-Cal mental health services is really split between these. Actually, there's 56 county-operated mental health plans in California and about 30 Medi-Cal managed care plans. And this is, again, often referred to as the bifurcated mental health delivery system. And just again, this bifurcation dates back to 2014, when to comply with the Affordable Care Act when California added these outpatient mental health services to the Medi-Cal Managed Care Plan package. And prior to 2014, adult Medi-Cal members with mental health conditions who did not meet the medically necessary criteria for the county specialty mental health services on the left here in pink or salmon, I don't know. These were delivered by primary care physicians or by referral to Medi-Cal fee-for-service mental health providers. So this really expanded the scope of non-specialty mental health benefits for people who experience mild to moderate impairment of mental, emotional, behavioral functioning, or intermittent challenges with behavioral health conditions. And also, as part of their responsibility, the managed care plans on the right, sorry, I know I'm ping-ponging a little bit between systems, are responsible for ensuring an adequate network of mental health providers and educating members about their right to the availability of these services. And so just to kind of illustrate this system of care in another way. So county behavioral health departments are really responsible for folks who have kind of meet the criteria for severe mental illness. And then local managed care plans have the responsibility to support individuals with mild to moderate behavioral health challenges. And the local managed care plans really delegate to a number of providers, including federally qualified health centers, to deliver this mild to moderate benefit. And just to get a little bit more concrete, I'm keeping this color coding consistent. So that, again, the specialty mental health program or benefit is the payer for that system is the county mental health plan, and the specialty mental health benefit includes adult crisis residential services, adult residential treatment, crisis intervention, crisis stabilization, day rehabilitation, intensive home-based services, medication support, psychiatric health facility services, etc. So you can see like more acute care. And then non-specialty mental health benefit is paid for by the managed care plans, and that includes individual and group mental health evaluation and treatment, outpatient services, psychiatric consultation, and psychological testing. And just to name here, some counties in California have much more robust systems of care for behavioral health than others, and there's, a lot of variability in access to these systems of care regionally across California. So just to name how FQs fit into this landscape and how they fit into the managed care part of the system specifically, FQHCs are contracted with managed care plans to provide the non-specialty mental health services. So for example, in terms of our Alameda Health Consortium and our member health centers, our health centers are all contracted with our local managed care plan, Alameda Alliance for Health, to provide the non-specialty mental health services. And just I illustrate that at the bottom here, you'll see the contracted providers like FQHCs and other behavioral health CBOs and agencies. These are the agencies that contract with local managed care plans and or the county behavioral health department to actually deliver the services. So that's where patients are being seen and clinicians are working. And also to name, it is possible for an FQHC to contract with both the county mental health department as well as the local managed care plan. A few of our member health centers in Alameda have both contracts with both systems. So that's also possible. I'm just going to take a quick peek again at the chat. I see Celine again. By local managed care plans, is that by city or county? Also, would you say MCPs are considered more preventative? That's a really great question. So by local, it's at the county level. And I would say that, would you say MCPs are considered more preventative? In general, perhaps yes, although managed care plans are also responsible for like medical services and contracting with, uh, like other medical providers like neurologists and other specialty providers as well. It's not just behavioral health. So in that sense, they also are responsible for like specialty health on the medical side, but maybe on the behavioral health side, I think you could say yes. Okay, so I'm going to keep moving here. Now I'm going to focus in a little bit more on specifically the FQHC model and what integrated behavioral health looks like at FQHCs. So integrated behavioral health is the collaboration between primary care providers and behavioral health providers under one roof. So this team approach works together with patients and families to provide patient-centered care for a defined population. And integrated behavioral health is considered a best practice in the non-specialty mental health system of care at federally qualified health centers. So you'll see on the right, this kind of illustrates the kind of team of providers and other care coordinator staff that works together to provide this integrated care. So that could look like primary care provider working together with a social worker or other behavioral health provider or a consulting psychiatrist. And it's really centered around the patient and what needs they have. Another important part of integrated behavioral health I want to call out is the role of care coordination. So every time someone is referred or needs support navigating from primary care to behavioral health within the same health center, often a care coordinator will come and help support that patient navigate to the system or the department that they need. And sometimes folks need referrals out of the health center. So care coordinators are really key in facilitating those processes as well. And so why integrated behavioral health? IBH, we also say IBH is the acronym, addresses stigma, mental health integration, really can help address stigma that can be associated with receiving mental health care. Some people might hesitate to raise their mental health care needs with a primary care provider, and that hesitance might delay treatment or getting access to care. So having a primary care provider ask about feelings of stress or anxiety or depression as part of the standard routine kind of workup can really normalize and destigmatize mental health system symptoms and the associated treatment. Also access. So for many, primary care is the first place you turn for physical or mental health need. And so it's a convenient opportunity for providers to ask about and screen for symptoms around mental health or substance use. And this practice can really help identify symptoms earlier, which can lead to earlier treatment intervention. Also, preventing physical health conditions. People with serious mental illness often can die earlier than their peers without mental illness, but the vast majority of these deaths are due to chronic physical conditions such as cardiovascular conditions, respiratory, infectious diseases, diabetes, and hypertension. And so behavioral healthcare integration really has the potential to address the physical needs of people with mental illness and vice versa by encouraging people to receive this preventative care. And then finally, I'll just name cost savings to the system. studies have shown that providing integrated behavioral health care at the right times can often offset the cost of providing more intensive behavioral health care, or can prevent the worsening of symptoms that can lead to more expensive and acute interventions like hospitalization or the emergency room. And I just wanted to plug, if you're interested in learning more about integrated behavioral health, there was a presentation from a couple years ago by a colleague, Erica Gomes, called The What and Why of Integrated Behavioral Health Care. And she does an incredible job from a clinician's perspective of really diving deep, and also kind of telling from the patient story of what integrated behavioral health can look like. So I've linked that in the slides, and I encourage you to check that out. And then finally, I want to just name some of the policy challenges that impede integrated behavioral health care delivery at federally qualified health centers. So one, if you work in behavioral health policy world at FQs, a huge one that has been on the table for a really long time in terms of advocacy is same-day billing. Unfortunately, FQHCs cannot bill for a medical and behavioral health visit on the same day due to state policy. And this requires health centers to provide uncompensated care and seek additional grant funding. And it limits kind of warm handoffs between primary care and behavioral health, and which creates a lot of barriers. So this policy barrier is really kind of foundational. Because of the same day billing barrier, it really is kind of the antithesis of implementing the integrated behavioral health model. And it's something that a lot of advocates and policy folks in California are really working to advocate for FQHCs to be able to bill for medical and behavioral health visit on the same day. Another policy challenge currently in the FQHC landscape is the implementation of something called Proposition 1. Back in March of last year, this was all on our ballots as a state proposition, and it passed by a slim margin. And Proposition 1 changes basically changes something called the Mental Health Services Act, which is another state policy that passed in 2024. And the Mental Health Services Act basically instituted a 1% tax on incomes over $1 million that since then has been funneled into the public behavioral health care system. And with the passage of Proposition 1, we're seeing a shift in resources, that's that state tax revenue, to more acute care and homeless services, which is so important. And we really need more resources to support that population. And unfortunately, it was a bit at the expense of prevention and early intervention services. So resources were shifted from prevention, early intervention towards more acute services. And that has, at least in Alameda County, where I sit, threatened the sustainability of some crucial programs, such as care coordination programs that I was mentioning earlier, and culturally driven prevention and early intervention programs. So I share these examples just as a very surface level taste of some of the policy considerations and kind of advocacy issues that our field is grappling with currently today. And then lastly, I'll just name one more. It's always a challenge to recruit and retain behavioral health providers at our agencies. You are probably, you may be familiar already with this, but recruiting and retaining culturally and linguistically aligned providers at FQHCs is really difficult because of competition with larger healthcare systems and private practice, et cetera. And this slide is purposefully meant to be overwhelming just to illustrate the why and the why now. Why do we have to be engaging in behavioral health policy here in California now, today? There's just so much coming down the pike in terms of reforms and changes in state policy. Some I've listed here, it's not even a full list. And sometimes I feel overwhelmed by the number of reforms and changes that are happening in our mental health delivery system. But to me, it's really, this slide is really part of my call to action in terms of really encouraging folks and clinicians and to get curious around the policies and the history of policies that have created the system that we have today and that we get to all kind of work together to shape moving into the future. And yeah, just again, back to this grounding question I started with, there's so much happening in the world of behavioral health policy in California, and just want to leave with this question of how do you want to shape it from here? And just to note that, you know, I've been doing this work. I'm still pretty new to this work, but if there's anything I've learned in the last 5 or so years I've been in this world, it's really kind of learning how to learn to love being in rooms with people who have been doing this work for much longer and know so much more and are just really have a strong grasp of the system. And I think as like systems thinkers and systems leaders, there's we really have to stay aware that there's just so much to learn about how the system works, and that it really helps to enter each conversation and each dialogue with kind of like a wide-eyed curiosity and also a willingness to kind of show up and play and engage in the space and offer the things that we do know and just be in a constant dialogue. So yeah, that's my kind of attempt to leave this group with a sense of empowerment and that we really can and must step up to create the system that we want.
I love that, stepping up to create the system that we want. So we have a couple of questions. Some are in the chat, some are in the Q&A. So I'll bring some in. I think one of them is about funding, or about payments. A couple of them are. So one of the questions is, and I would expand this question out of it. Have you received any new guidance on whether MSW students, and I would say also if they're PCC and MFT students, so we'll have all of the master's level licensed students doing their internships in FQHC can provide reimbursable services. So do you know anything about sort of the landscape on, can student trainees can their services be billed for?
Totally. Yeah. So that's a really great question. And there's been a lot of, within the last few years, kind of expansions in the types of billable providers that, that FQHCs can bill for. So ASWs, AMFTs, of course, LCSWs have always been a billable provider type, LPCCs. There's a couple, like LMFTs are new provider types, and there's some administrative processes happening at the state level to actually make that actualized. But we are hoping and that is a key kind of part in terms of behavioral health advocacy that I think about is expanding the number of billable provider types at federally qualified health centers specifically. Currently interns, like student interns, there are not billable across the board. So FQs really lean on grants, including state grants and federal grants, to be able to support student interns.
Yeah. So it sounds like ASWs, APCCs, maybe AMFTs, like those. So those are post grad but pre-licensed. Are we're starting to get that, but there's still kind of a barrier on students, people who are pre-degree being able to be billable. But I
Mhm.
have heard of some agencies using, yeah, like other
Yeah.
grants or private funding or things like that to then bill for that, or having coming up with creative ways to do that.
Yeah, and
Um,
I think I'm hoping we're going to see more. There's a state waiver now called BH Connect that has earmarked $1.9 billion for workforce stipends and other things like that. So um, it's a little iffy in our current environment right now, but hoping that those are opportunities that will come through in the next period.
Awesome. Okay. And then we have Yesenia asks, what insights can you share about psychoeducation groups in IBH? How can providers obtain reimbursement for these culturally significant interventions? So do you know anything about group interventions?
Yeah, that's such a good question. Yeah, a lot of our health centers provide groups of varying types and kind of themes and yeah, etc. And this is another one where there's somewhat of a billing barrier. Um, However, our health centers still hold groups, but the way it works is at FQs, a group can only bill, like if you have 10 people in a group, you can only bill for one visit,
Oh, wow.
which is a significant barrier, but it still
Yeah.
happens. And our health centers also use grant funds to support groups in psychoeducation.
Okay. So more still creative funding to try to do
Mhm.
that. And then
Exactly.
you did mention that piece, right, about the you can't bill on the same day for a medical visit and a behavioral health visit. And so I was wondering if you could just, that seems like such a huge barrier for doing the good IBH work. And so if you could just say a little more about that, if there's any advocacy or anything that any of us could be involved in, that would be helpful.
Yeah, absolutely. I mean, this has been just ever since that 2014 turning point of the integration of non-specialty mental health into as a Medi-Cal service. This has been a long-standing barrier, and there's been many iterations over the years, over the last decade, I would say, of advocacy at the state level, and federal level to try and get around this policy barrier. And this is like the constant kind of number one IBH policy priority. So there's definitely opportunities. If anyone's interested, I'm happy if you want to reach out to point you to different opportunities. But most of it is being led by our state association, the California Primary Care Association.
Okay, so California primary care. So that also sounds like a good place if you're interested in doing this to maybe make sure that you're connected with them. Are there any other organizations like that if folks are interested in kind of being up on the policy, places that our attendees could connect with that might help them figure out how to advocate more for this?
Hmm. Yeah. Hmm. Definitely CPCA. So CPCA, the California Primary Care Association, is the state association of all federally qualified health centers in California.
Okay.
So they cover not just behavioral health, but all kind of primary care within FQHCs. And they have ties to state and federal government. And there's so many advocacy organizations. There's family organizations, like consumer organizations that are led and made up of folks who have or have family members with severe mental illness.
Mhm.
There's yeah, and I'm happy to follow up. There's just so many.
For sure. Awesome. Um, okay, and then I'm looking to see if we have any other. We've got these ones are answered. I'm just scrolling through the chat in case there were any in here. I see that there was an issue with the evaluation link. I just was able to share the updated one. I think maybe we were sharing one from an earlier webinar there. So I feel like we've had seamless ones for the last several whiles, and we've had more tech challenges this session than we've had in a while. Okay, I'm not seeing any more questions in here. Here we go. No, so yeah, no, I just want to really thank you. Unless any of my co-hosts have any additional questions, they're welcome to kind of unmute themselves and bring them in. But I think it was really, really helpful to kind of get the walkthrough and the bifurcation of the system. I know I feel like I hear this information all the time and then it kind of fades away. I guess I do have one question, and this is kind of an out of the blue, and I'm not sure that you have it. So it might, you can just say like, I don't know anything on that or don't want to comment on it. But I know there's the big challenge around are we still are they going to take away access to telehealth? Is that going to be renewed or not for Medicaid broadly, and then how that would impact us? So I'm curious if you have any sense of how that might be impacting behavioral health in Alameda or locally if that doesn't get extended, the access to telehealth and Medicaid payments.
Mhm. Yeah, I don't have my finger on directly on the pulse on that one. I know that there have been a lot of threats to or restrictions, potential restrictions on telehealth in the Medicare space that kind of have been pushed back month after month. And those are extensions and flexibilities that came along with the public health emergency during COVID. So I know about that, but in terms of telehealth and Medicare more broadly, I think as with a lot of these federal changes and shifts with the new administration, there's a lot of kind of waiting and seeing to see how things end up in the final budgets and continuing resolutions and all of that stuff. Yeah.
Okay. We had one last question come in, so we can maybe end with that, and if there's any final thoughts you want to close with. But someone had a question about, do you know anything? And you might not know at this basic level here, but any billing codes that might work for graduate intern providers. So do you know anything about that?
Ooh. So my expertise, I'm not a clinician, so I know very little about billing codes. But someone like Erica or others, any clinical clinician at FQHCs would definitely be able to share more. Sorry, that's
It's
that's
okay.
out
Yeah,
of
I
my
thought that might
league.
not be in your
It's
wheelhouse.
okay.
So
That's
yeah,
what I
yeah.
love
So
is that, we all bring the different perspectives and orientations to this work, and it's all, we need it all. So, and we need clinicians who are doing this work as well.
absolutely. So yeah, thanks for that. And and that was Erica Gomes. So for the person who asked, the anonymous attendee that asked that, the earlier we posted the link to Erica's most recent. She did an updated version of her that one just at the beginning of the this academic year. So last fall she did one. And so we put the link to it's on the YouTube channel that we have that has all of these. And I think her contact information is on the slides with that, which you can always find at our it's ibhequity.sfsu.edu/webinars, and you'll see all of our archived ones and all of the slides for them, which is also where you'll find the slides for this one. We'll post the recording of this one along with the slides from this and the evaluation links for those of us who are getting their stipends from us that need to complete that. So I think that's everything. We're just about at the end of our time. Thank you again so much, Mia. We really appreciate you sharing all this information. You're getting a lot of thank yous and claps and, and appreciation. So thank you, thank you. And yeah, everyone have a really good rest of your Friday, rest of your day. Thanks for spending an hour learning about FQHCs with us today and so we can all practice integrated behavioral health.
Thank you all.
Yeah, take care. Bye, everyone.